my privilege to have you, Fabrizio, as a host today for delivering this lesson among one of your topics of expertise, of your recognized topics of expertise, which is artificial intelligence. Everybody's talking about that, but it's not easy to understand. To understand what it is easy, but it's not easy to understand which are the potentials for AI to conduct a good quality research program. So I'm sure that today you will illuminate us in understanding better this.
Yeah, thanks, Bernardo. Illuminating probably is a bit difficult, but I will try, how to say, to dissipate some shadows on this. And I began taking care of AI, I think, 6 years ago. And this technology, or how we want to define it, has dramatically increased in these in these years. First, all of us here do a lot of research, and all of us mainly do traditional research. Traditional research was started probably by Galileo Galilei a long time ago, and basically all of us do some observation on his clinical practice, for example, about drug-eluting balloon. Then we create a theory. Then we use our theory to form an hypothesis, and then we try to perform a study, a meta-analysis, randomized control trial, and observational studies to test our hypothesis. This is the classical way to do research. Artificial intelligence is probably dramatically changing this landscape. Is a huge definition. Artificial intelligence is something that allows machines, allows algorithms to perform like human beings. In the great field of AI, there is machine learning. Machine learning means that computers are able to perform some specific tasks without being explicitly programmed for this. And the very famous example is that the machines which beats human beings at playing chess. And then there is deep learnings, that algorithms that adapt and modify themselves from a huge number of patients. So when we usually do research, we always are looking for causality. In AI, causality is not needed because I try to find also not linear relationship between data and our endpoints of interest. There are different forms of machine learning. The one which I use, which most of researchers in medicine use, is supervised learning. That is, we give a lot of data, for example, a lot of data about drug-eluting balloons patients. The algorithm works and, for example, try to extract the features of them who would benefit more from DEB rather than permanent stents, but under, for example, Bernardo's inputs under Vana ideas, and then he gives the output. Unsupervised learning is something which is very far from our practice, but is basically we give the huge amount of data to the algorithm, and the algorithm works and gives us the output without any inference with human beings. And this is quite different from traditional research, and also quite different from what, for example, till now we had done in Turing and also with Vana. So AI is very important in different fields. We did a lot of stuff about risk prediction and individualized analytics, but it's also very important for computer vision and for system performance. Computer vision means that, for example, this is a nice paper which was published in Nature, I think 5 years ago. It may help to reduce the radiation of CT. We know, all of us, I don't know in America, but in Italy, CT scan is crucial for detecting coronary stenosis, both in the emergency department and also for stable patients. It improves the quality of the images. It improves, it helps for segmentation. For example, think about echocardiography or CMR, shape analysis, and also for disease classification. This is a nice paper because these authors try to understand if machine learning may improve the diagnosis of fetal disease from echocardiography. And this is a classical example of how machine learning works. That is, they give a lot of videos of echoes. I'm performing a similar task on echocardiography, and it's very difficult to make machine learning algorithm to adapt and to understand from the videos and to transform into signals, and then they give an output. In this case, is the output is that, for example, they correctly identified all the areas of the heart of this fetus. So with the first, they tried to learn if the images was with 4 chambers or without 4 chambers. They tried to understand if the images was of good quality or low quality, and then they tried to detect the structure that we're looking for. For example, this is a correct, and on the right, on the left, a wrong detection of pulmonary vein angle, which is very important for detective disease of fetus. So this is one of the example, very basics that we can use machine learning. Moreover, this is a big study. You see that's the only limitation from my point of view, or better, from an Italian point of view. I know that's in the USA, they have a lot of amount of data already stored. I think the Mayo Clinic has more than about 1 million of HEG stored. So it's not a big issue for them. But in Italy, Bernardo and Marco knows better than me, that it's very difficult to store images in, I don't know, in other countries. So you will see a lot of number there. So they derived this project on 2,050 patients and validated on 20,000 patients, and they simply, with machine learning, try to accurately classify the echo to predict the ejection fraction, to predict the alteration of kinesis. And this is very important because in few years from there, for example, to nowadays, the algorithms beat the human performance. So machine learning is clearly superior in this field towards humans. And this is another paper, I think very interesting, which was published by the group of Professor Indolfi in JAMA, and it was about of multi-channel HEG obtained by a simple smartwatch to diagnose ST segment changes. They give this peculiar smartwatch to patients who had a prior myocardial infarction and who had a high risk for recurrence. And when the patients adverted chest pain, they put this smartwatch here and tried to understand if they had a ST segment elevations or not. And this paper demonstrated that with machine learning, they achieved a good performance. Sorry, 1 second only. And this is the accuracy in which you see that the difference between the traditional HEG and the HEG predicted by machine learning was very, very low. Another thing is always to segment, that is to delineate the various anatomical or pathological regions or images. This is very time consuming. I don't know if any of us perform echo in their routine clinical practice, but it's very time consuming. And for example, in this paper, they use again a huge number of patients, about 1,000 patients presenting with dyspnea, and only from ECG they were able to predict or not the presence of left ventricle systolic dysfunction. And this may be very of help, because I think that it is the experience of all of us that when you are called in the emergency departments, not always is an echo is available. Sometimes it's very difficult to perform echo because there are a lot of patients coming there. And if you can very simply predict and discriminate those with left ventricle dysfunction versus those without, it may be of help. And here you may see a very impressive, I think, area under the curve. I think that in this brief presentation, I will show you a lot of how around 0.90. This was very infrequent because before machine learning, I think that the gray score was one of those performing best, and the AUC of the gray score was about 0.75, no more. So with machine learning, we easily achieve an AUC of about 0.90. And here again, they tried simply without using volumes to quantify the AEF, without using the classical manual classification of volumes, and they were very able to perform, and to achieve a correct and an accurate EF. I will not speak about this, but I will speak about another great topic of interest. I think is individualized analytics, that is to create and to understand which group of patients who presents with similar features one among the others are at increase or not risk of adverse events, and this may help us to select patients. For example, this paper was accepted from our group, was accepted a few days ago on the European Heart of Digital Health, and we enrolled a relevant number also with the great help of Vanna and this group. We enrolled a relevant numbers of patients with severe or moderate MR undergoing MitraClip, and with machine learning we created 3 clusters of patients. You see the first cluster was one with the highest years old. It was much more frequently the first cluster with diabetes mellitus, and the first cluster and a clearly more prevalent ischemic etiology, and with a more severe left ventricular dysfunction and more severely dilated left ventricles. And also at right heart catheterization, you may see that there were clear difference between, for example, the mean systolic pressure, which was low, for example, in cluster 3 and higher in the other cluster, and also the cardiac output, which was clearly low, in the second cluster. And this cluster, which was based, again, I repeat, only on machine learning, without particular clinical input, clearly defined and divided the outcome of the patient. This is the 1 year follow-up endpoints. You see that patients in the first 2 clusters had a higher risk of death, cardiovascular death, or heart failure hospitalization compared with those in the other two clusters. And this helps us to create a 4 clinical phenotype. That is, when we see a patient with a moderate or severe MR, we only can use this very simple baseline feature, the presence of the diabetes mellitus, the presence of CKD, the age, and this may help us to understand and to discriminate between prognosis, between them at high risk and them at a low risk of both death and heart failure hospitalization. To be honest, we wrote also some score, but this is much more helpful because it's much more clear and related to our clinical practice. Another paper very similar we wrote about Takotsubo. I spent some time in Zurich and I was impressed by the high number of Takotsubo patients coming there. Sometimes we are used to seeing that Takotsubo basically is a benign event without a negative prognosis. Otherwise, there is still a risk, I think not so low, of in-hospital death, which is about 5%, and we created this 3 cluster. For example, you see here that this is a shape analysis diagram discriminating, you see in red, clinical features increasing the risk of event, that is white blood cell, cardiogenic.
So females are protected as compared to
they are always protected. But this is strange because I think that 80% were female. A male came for Takotsubo. This is, I don't know in your experience.
Few of them.
Very few of them.
Yes.
I don't know Vanna in his experience.
No, I don't remember.
Very few. So cardiogenic shock, physical stress, of course, acute neurologic disorder, age, increase the risk of in-hospital death. By all these things, as Bernardo says, also female gender were clearly
We did,
protective.
we did, sorry to interrupt, we did a nice case, one of my first case reports, so it's a lot of years ago. This was a lady which came with I called it a migrant Takotsubo. She came with a typical apical ballooning, and then after 2 days, so coronarography negative or that, after 2 days, there was a Takotsubo pattern in the inferior wall. That's unbelievable. Of course, we have the ventriculography for the first one. For the second one, we have the echo, which was showing a ballooning of the inferior wall, the proximal inferior wall. That's so migrant Takotsubo, and that was a 90-year-old female, 90-year-old female. But that was in Liguria, so they are weird people in Liguria. Strange people there. Yeah.
But did she recover or not?
Yeah, she recovered them. Now she would have 110 years. So
no, I think that now is a bit too much.
She's gone. Yeah. No, I have a question for you for this. So have you ever tried to do something for SCAD, for spontaneous coronary dissection?
Yeah, we were thinking about this. I think that's we may reflect. I think this is a good idea. I think, to be honest, I'm much more interested in long-term prognosis than in short-term prognosis in this field. But I think the SCAD is a very interesting field of.
Yeah, they are young persons. So it's. If you want to do something, we can collaborate. Let me know. I'm involved in SCAD patients. So
I think this is a very good idea. Also because they are young, and and also because they are multifactorial as a surgery, so it may be of help. Okay, thanks. And so we were able to create these 6 clusters, and again, you see there is a huge increase of in-hospital mortality. See, there's a patient with these features, high-risk feature, older, male, presenting with acute neurologic disorder and cardiogenic shock, at a higher risk of death compared to all the other. The other stuff in which machine learning may help us is the system performance. We know that it's very difficult sometimes to predict correctly the area, the presence or absence of coronary sinus, for example, for TAVR implantation. We know that there are a lot of programs, all of us use them, but sometimes it's not very difficult, and sometimes our surprises still expect us in the cath lab. And for example, here this author presented a program which, to be honest, I also tried to find it online, but I was not able to find. I don't know if there are some issues with patents, but anyway, they tried to develop this program, allowing us to predict the performance of different kind of valves. In this case, it was 5 years ago, so Sapiens versus core valve, the Evolut, and with AI they were able to predict the presence or not and the relevance of paravalvular leak, and also the maximum points of contact for all these prostheses. And I think that this
that's very interesting. For example, because AI is a very powerful tool, but as you clearly depicted from the start of this presentation, we are clinicians. Okay, so we don't need to have another publication. We don't care about that. So we start from a clinical problem, that current data, randomized trials, observational data do not respond to. So while you are showing all of these studies, there are many still clinical questions that are arising in my mind that current data do not respond to. So that's really the beauty of this artificial intelligence, and that's very, very open-minded.
Yeah, also because sometimes it makes you reflect, because I think that sometimes it shows you association that we were not thinking by medicine, by what you learn, by your experience. So I think this is also very, very nice. For example, this may be of help. For example, because if it helps you to predict complications from a CT scan, from some simulation ideas, I think that this may be very interesting in the cath lab, because still we have some complication after TAVI. And of course, if we want to implant TAVR in a young patient, we have to be sure that we are very competitive and we are doing our best. We are competing, of course, for surgeons. So I think that this may be also very interesting. So we know that there are still a lot of things, as Bernardo said, that we may do. We have to increase our system performance. Of course, the other stuff, all of us read a lot of scores about AI, and as I told you before, the performance dramatically increase with machine learning. We published the praise score on Lancet now 5 years ago, which we developed and we recruited a lot of patients. To be honest, all these data sets were retrospective, so they were not very high quality data set, as all we know, because they are retrospective. We validated into prospective studies, so probably this increase the qualities. We perform different models of AI. You may see here from boosting to random forest to try to understand the one which performed better. And to be honest, this was very easy, because you may see here that the feature that predict death, myocardial infarction, and major bleeding, we all know them very well. We all know that reduce EF, increase age, reduce hemoglobin level, and reduce renal function, increase the risk of death. We don't need machine learning to know them, of course. And as perfectly here for the risk of recurrent MI. But for example, here, we know I was surprised by this, because as all cardiological data sets, we did not collect variables very relevant for bleeding, because patients who bleed from the stomach, we bleed from the colon. So usually we do not collect data about this. But machine learning was very able also to predict in an accurate way the risk of major bleeding, which I think is the weakest point. Rather than myocardial infarction or causes, is the weakened points of prediction after HS.
LVEF, so reduction LVEF is correlated to major bleeding.
Yeah, because I think is a reflection of a systemic dysfunction. Now, if you reduce AF, probably your liver function will decrease, and so this will, and also your renal function, this increase the risk of bleeding. I think this is simply a reflection of systemic dysfunction. And you see, and this was very strange, because we achieved a very good AUC, and also paradoxically, sometimes the AUC on external validation, you see the blue one, were higher than the AUC of internal validation or training or development. I think that you may see all this stuff only with machine learning, because with traditional score you cannot achieve this, and you may see the side of risk which are very good. So the questions, as Bernardo says, is which is the clinical impact of all of this? Because I show you some studies, so it was very good. This was a review which was published in Lancet 5 years ago, and they tried to compare deep learning models, you see on the right, versus healthcare professional to detect disease from medical images, so from CT to echo to MR in all the fields, not only cardiology, but also medicine, oncology. And you see that the deep learning models increase not particularly the specificity, but increase the sensitivity a lot. So this is very important, because from the point of view of diagnosis, I think that the field of radiology is still changes, but will change dramatically in the next year. And about the clinical impact in all the studies, we should remember that AI, unluckily, was mainly evaluated only in observational studies. This is a review published some years ago. Most of the studies are not randomized controlled ones, and Bernardo now is working in USA, and he knows that randomized evidence is needed to achieve some algorithm on some device into medical practice. So the performance on AI in RCT, one of these was positive for AI, and the other was neutral. And of course, in the observational studies, AI achieved good performance, but of course, these studies were biased by the usually, and we know better, you all know the risk of bias of this. So this is how to say the conclusion of Topol, which I think is much more important than me, that he says that probably AI will help us in all these fields to understand the disease, to try to offer a more accurate diagnosis in a faster way. In Italy, in this day, we are bound by the timing of patients who cannot do also very important exam in the correct time, but it will never substitute our work. Thank you.
Oh, great, Fabrizio. You you did a very nice and complete picture of the thing. I really learned. Oh wow, 60 slides. you you did it in a proper time. We have a lot of questions and things that we would like to go a little bit deeper in understanding. So you guys, which questions do you have for Fabrizio today? Which doubt or criticism?
Yes, thank you very much, Prof. Dr. Fabrizio, first of all, it's a great privilege and honor to have you here. It was a very comprehensive lesson. I learned a lot, and I found it personally very fascinating. I believe its potential to enhance diagnostic accuracy and in terms of predicting risk factors and prognosis is truly transformative. It was a very nice lesson. Thank you very much.
Thank you.
So, thank you, Fabrizio. Very nice. Congratulations, the lecture. You're the top of the AI, I would say, in the world. And I have the question.
No, in this room, in my room now, huh?
No, I don't think so. We are talking about AI in Turin a lot when I was there, and we are talking that the final step of the AI techniques, AI device will be to perform the randomized clinical study, which were in one side will be decision created by AI, and the second decision will be created by physicians.
Yeah.
And how near, how close are we to those kind of the study, and are there any study, ongoing study which are doing like which are trying to compare physician and AI decision?
For example, there was a study in which many patients were randomized to SCC diagnosis based on AI versus HC, but for all admission to AD, not only chest pain, and it demonstrated superiority. I think that it's difficult for the reason that you need a very good insurance, of course, because at least in Italy, but I think also in the United States of America, and of course you need someone who pays for developing the algorithm. So I think that is an amount of money and of funding rather than interest, because till now we are used to big pharma that create randomized control trial or rivaroxaban versus that's a new drug-eluting balloons or versus the new valves. But I think that the limit probably is the absence of big players in terms of AI applied to medical stuff.
Yeah, this is one important thing. The other limitation probably so far for doing, using more this technology is related to the possibility to have huge databases.
Yeah.
So the owner of huge databases, we are about to start this study for DCB, for example, together. So the owner of these big databases will have a lot of power, really a lot of scientific power, and maybe not only scientific, I have to say.
Yeah, I think that Google has a lot of data. I think that's also medical data is collecting. But the other stuff is, for example, we did some interview for big companies in Italy. And to be honest, at least in Italy, I cannot tell for the name, but they are very far from what we are interested now. For example, they came to us to say, why don't you analyze the ergometric stress test performed in patients, in health patients in the 80s, 30 years ago, to predict the risk with AI. So, but 30 years ago, the primary prevention was totally different, and now, so my father smoked, I don't smoke, for example. So I think it's also it's sometimes very difficult to communicate with this, because Google, for example, I lucky it was not Google that came to us, but Google probably is not very close to medical issues like, for example, Medtronic has been for years. So it's also, I have to say, a matter of communication.
Yeah, I think that another topic is also ethical, because the owner of this data, if you own this data, you as a scientist, it's one thing. If a big company with a specific interest is another thing. So if you own the data, you may decide if to disclose the data, or you may also decide, okay, we analyze, don't like it, so let's not disclose it. So that's with a randomized clinical trial is different. If you have the money and you don't need the huge amount of money, you can run a important randomized clinical trial to respond to your question, or you can do a large, well done prospective registry. You can do some good science, but for this data, the owner of this data is very powerful.
Yeah, and also for the point of view of patent, it's very difficult sometimes because you have to perform a study and to tell the patients that you are doing a patent on their data, and also of course to tell the hospital. So it's a very difficult. I was trying to create. I'm trying to create a dedicated. How to say? I don't know the term now. Percorso. I don't know the terms in English now. It's shifting from
Or path.
A dedicated path. Perfect.
Path.
A dedicated path for patents, for medical patents in my hospitals, also to speak with the hospital,
That's
with
nice.
the university, but it's something that we are in Italy, of course, it's very difficult, but this is, I think this is important because, of course, we have to do in a good and accurate way.
And yes, and you need to have fundings for doing this research. You cannot do it alone.
But in our university pays for the patents because you gives to the university a percentage of the patents and they help you. This is the positive stuff.
This is good. Yeah.
And one more question. We are a DCB group, so fan of DCB. So how do you think? How can we use AI in terms of use of DCB as invasive cardiologists? As we performed last time the study using AI and OCT in terms of plaque morphology. However, it is we after stent implantation. What do you think it's possible to perform quite the same study using DCB, or it's necessary? We need those kind of study. Do we? It will help us. It will help us in the future when we want to decide to use DCB or stent in terms of the plaque morphology, and maybe AI could help us to tell us to give us the decision, help us to put the decision DCB or DS. What do you think about that?
Yeah, actually, I just want to add how to standardize our, in a short, how to standardize our final results on the basis of artificial intelligence because we are working on DCB and every day we are doing something new. So there's any standardization of the final results, how we can standardize it?
Could be.
Yeah.
I don't think that there is. Could be. Could we predict the calcium morphology move as you say, as you show us the study about TAVI? So AI could predict the movement of the calcium after valve implantation. There are some studies which show that. However, we could use also AI, much deep learning, to predict the movement of the calcium and how the lesion will behave after DCB treatment.
Yeah, no, I feel that we may, if we may have a randomized trial on DCB versus other stuff, we may use to create a cluster of patients who benefit more from DCB than coronary stents and vice versa. And anyway, if we have intracoronary imaging before and after DCB, both IVO and OCT, we may use this to predict the movement of calcium, the response to calcium after, for example, shock wave, to predict also the minimal area after DCB implantation or the stuff. So I think there is a lot of possibility of research also with machine learning in these fields.
Professor D'Ascenzo, thank you for your lesson. I have only one question. When the machine learning splits the population, such as for your paper on mitral transcatheter edge-to-edge repair, the investigator gives an input, or immediately the system is able to split the population in cluster of risk.
No. The system is able to split the population by itself, but it needs inputs. For example, in the risk score on HES, the engineers came to me and says, we found a nice thing that's Ticagrelor increased the risk of bleeding compared to Copridine. I said, very interesting thing. Yeah, of course. So it needs some help from us, of course. It still needs help. For example, there, to be honest, it was good, but is all, for example, I think that also Bernardo and Vana, we do also statistics for ourselves, but sometimes when we speak with statistics guys, they still need our inputs. I speak here about traditional statistics, and machine learning is the same stuff. They need our input to understand what is reading, basically.
So far at this stage, okay, so far we are useful for something. In a few years, who knows?
But as interventional cardiology, probably we will still be useful in next years. As radiologists, I don't know.
Yeah. Nice. All right, thanks a lot. Any other question for Fabrizio? Oh, that was really, I have a lot of things in my mind. I was taking some notes. Now I have a lot of things we can do together, man.
Super.
I will contact you. I will contact you.
I know.
Let me sediment, discuss with the team, and then we will come to you with some proposal.
Pleasure for me.
Yep. There is one more thing I just want to add. We have one more thing I just want to add here. We have a research program in our hospital, and the guy, he asked me that what topic you want to have a research. I said that there are certain DCB topics I want to research for it. He said, okay, we will take the outline from the artificial intelligence. He asked me the topic. I have given him the topic, and by putting the artificial intelligence software, he was having a complete article outline, like a synopsis.
Yeah.
So have you any idea about this? I was very surprised.
Yeah, but I think that's, for example, I know that all probably know Professor Biondi Zoccai, and he was involved by the ESC in a document about secondary prevention after COVID, cardiologic, and he gave me a chapter about cardiological use of aspirins. But as experiment, he asked, I think, ChatGPT, ChatGPT to wrote all the documents, and ChatGPT wrote all the documents with the paragraphs it holds. But when I read it, I had to modify, because, for example, in my chapter, he says, okay, after COVID, you have to walk a lot, you have not to stress, you have to eat a lot of fruit and vegetables, so you don't have to eat too many cakes or something. And it is obvious, okay? But he didn't speak about if it's good to perform vaccination or not,
exactly.
if it's good to give aspirin. So the things that were written by ChatGPT were correct, of course, but were not very focused on the topic. So I think that's but sometimes I think Suno is not Suno. I don't remember now. I will send later to do central figure, right? That you give a text and AI creates
nice.
A figure.
What is that?
Nice.
We want to know that.
I will send the link.
This is very
later.
good.
Please.
I will send the link later. I don't remember now. I know Suno, but is now I not remember. But anyway,
good quality figures, good quality pictures.
Nice figure, nice figure. Very
central for good quality, good publications.
Yeah, similar to BioRender sometimes. So it's very good.
Yeah. All right. Thanks a lot, Fabrizio.
Thanks to you. It was fascinating.
Thank you. Maybe I'll see you in Paris in a couple of months.
Yeah, I offer complimenting for creating this nice group. Thank you.
Thanks a lot. Have a nice day.
Bye bye.
Thank you very much.
Bye bye. Thanks.
Bye bye. Thank you.
Bye bye.
Bye.